Welcome back, everyone, to another edition of The Explainer. I am so thrilled to have you tuning in today because, honestly, we are diving straight into a biological detective story, and it's one that takes place inside the deepest, darkest factories of the human body, the bone marrow. Just think about that for a second. What happens when the very cells meant to protect you actually turn your bones into a battleground? It's a fascinating, albeit terrifying premise. Today, we're unmasking multiple myeloma. It's a disease where the body's own immune system essentially goes rogue, and it bridges this crazy gap between complex microscopic pathology and the very real physical stakes for the patient.
All right, here is our game plan for today. 1. Meet the rogue cells. 2. Hijacking the bone factory. 3. The CRAB symptoms. 4. Clues and diagnosis. And finally, 5. Treatment and hope. Let's jump right in.
Section 1. Meet the rogue cells, specifically looking at plasma cell dyscrasias. Let's find out who exactly is orchestrating this internal takeover.
So multiple myeloma is a malignant neoplasm, which is just a medical term for a cancer of plasma cells. Normally, these are your post-germinal center B cells, right? They're specialized microscopic factories that produce a wide variety of antibodies to fight off infections. But in multiple myeloma, it's like a single defective worker takes over. One defective plasma cell clones itself relentlessly. This clonal proliferation maliciously packs into the bone marrow space. And instead of making useful, diverse antibodies, this clone army just churns out one totally useless identical antibody known as a monoclonal immunoglobulin, or M protein.
Now, when you're tracking a suspect, you have to know their profile. This disease doesn't usually strike the young. 60 to 70 years is the peak incidence age. It almost entirely occurs after age 50, and demographically, we see it more commonly in males, with a notably higher incidence in populations of African ancestry.
So what's driving this? The molecular blueprints for this heist are all hidden in the genetics. Why do these cells go bad in the first place? Well, we frequently see translocations involving the immunoglobulin heavy chain locus on chromosome 14q32. We also see cyclin D dysregulation, chromosome 13 deletions, and MYC abnormalities. Plus, there are mutations that activate the NF-kappa B pathway. But listen, pay close attention to interleukin-6 or IL-6. This cytokine is the ultimate survival fuel. It's the major growth factor that keeps these myeloma cells alive and thriving inside the marrow.
If we pull these suspects down to the pathology lab and put them under a microscope, they have very specific mugshots. The abnormal plasma cells have an eccentric nucleus, meaning it's physically pushed off to the side with what we call clock face chromatin, and a pale area right next to the nucleus called a perinuclear HOF. But what's truly bizarre is how they literally hoard the useless proteins they produce. When this immunoglobulin junk accumulates in the cytoplasm, we call them Russell bodies. And when it gets stuffed directly into the nucleus, those are called Dutcher bodies.
Section 2. Hijacking the bone factory. Osteoclast activation. So we've got a marrow completely packed with rogue cells hoarding junk protein. How does this actually affect the structural integrity of the patient?
Well, our bones are constantly being remodeled by two teams working in tandem. You have osteoclasts, which are the demolition crew that breaks down old bone, and osteoblasts, the construction crew that builds new bone. In multiple myeloma, the myeloma cells secrete factors like RANKL and MIP1-alpha. These violently stimulate the osteoclast demolition crew into absolute overdrive. And at the exact same time, the osteoblast construction crew is actively suppressed, so the balance is just entirely shattered.
Because you have this unchecked demolition with zero construction going on, the bone matrix just falls apart. The bone marrow fills up with these soft, gelatinous hemorrhagic tumors. On an X-ray, this literally looks like someone took a hole puncher to the bones, producing what we call punched-out lytic lesions. Obviously, this causes severe, persistent bone pain, especially in the back, and leads to pathological fractures, where bones like the vertebrae, skull, ribs, and pelvis can simply collapse under normal body weight.
Section 3. The CRB symptoms, end organ damage. The destruction of the skeleton is just one piece of the puzzle. We need a way to easily identify the systemic damage.
Okay, if you take away absolutely nothing else from this explainer, remember CRAB. This mnemonic is the definitive signature of end organ damage in multiple myeloma. C stands for hypercalcemia, because all that destroyed bone releases massive amounts of calcium into the blood, which causes constipation, confusion, and muscle weakness. R is for renal failure, primarily because the kidneys get completely clogged with those junk proteins we talked about. A is for anemia, specifically a normocytic normochromic anemia that causes intense fatigue, simply because the bone marrow is too crowded with cancer cells to make normal red blood cells. And finally, B is for the bone lesions we just discussed.
Let's trace how this builds into a complete pathogenic chain. Step 1. The clonal plasma cell proliferation begins. Step 2. These cells do two huge things simultaneously. They pump out monoclonal immunoglobulins while overactivating osteoclasts. Step 3. This dual threat systematically dismantles the body, culminating in bone destruction, severe renal injury, and profound immunosuppression. Because the body stops making normal, healthy antibodies, it leads to frequent infections by organisms like Strep pneumoniae. Section 4. Clues and diagnosis. Clinical findings. Now that we know what the damage looks like, we enter the detective phase. How do clinicians actually prove this is multiple myeloma?
First off, doctors have to differentiate between an active threat and a waiting game. There's a precursor condition called MGUs, monoclonal gammopathy of undetermined significance. In MGUs, you have that rogue M protein, but the clonal plasma cells make up less than 10% of the bone marrow. And crucially, there are absolutely zero CRAB symptoms. But the moment those plasma cells cross that 10% threshold, or the patient starts showing the CRAB features, kidney failure, bone holes, high calcium, that MGUs upgrades to a confirmed, active diagnosis of multiple myeloma.
To find that abnormal protein, we run a test called a serum protein electrophoresis. Normally, antibodies show up as a nice, broad, smooth curve on the test graph because they're incredibly diverse. But in multiple myeloma, we see the M spike. It is a massive, sharp peak right in the gamma globulin region. This is the undeniable fingerprint of the rogue cell clone churning out identical useless weapons, most commonly IgG, followed closely by IgA.
Sometimes these cells produce only the light chain part of the antibody. These free light chains are filtered by the kidney, causing serious tubular damage, and they're excreted right into the urine. We call them Bence Jones proteins. The classic, almost magical laboratory test for them is the heat test. Get this, if you heat the urine, the proteins precipitate and get cloudy at 40 to 60 degrees Celsius. Keep heating it to boiling, and they completely dissolve. Let it cool down, they mysteriously reappear. It's such a fascinating quirk of biochemistry that serves as a really brilliant diagnostic clue.
And there are even more visual clues left at the scene. Because the blood is so incredibly thick with excess immunoglobulin, red blood cells actually lose their repelling charge and stack together like a roll of coins, a phenomenon called rouleau formation. This also causes a very high erythrocyte sedimentation rate, or ESR. If you look at an X-ray of the patient's head, you'll see a literal raindrop skull appearance due to those lytic lesions. And clinically, the patient will suffer frequent infections because their normal humoral immunity has just totally tanked.
Section 5. Treatment and hope. Managing myeloma. The sheer scale of this internal sabotage is definitely daunting, but modern medicine does not leave patients defenseless.
Before launching a counterattack, doctors assess the severity of the invasion using the International Staging System. They stage the disease from 1 to 3, largely based on a really critical chemical marker called beta-2 microglobulin. If beta-2 microglobulin is low, that's stage I. If it's high, it tells doctors the heist is advanced and dangerous, classifying it as stage 3. High levels of this marker, along with renal failure and a high tumor burden, are unfortunately poor prognostic factors.
But look at the counterattack arsenal we have today. We use highly targeted chemotherapy regimens, featuring drugs like bortezomib, lenalidomide, and dexamethasone. For eligible patients, an autologous stem cell transplantation can effectively reset the marrow. To fight the bone destruction, we deploy supportive bisphosphonates. These physically shut down the osteoclasts and help rebuild bone mass. Alongside aggressive hydration and careful infection management, this multifaceted approach has completely changed the landscape. While multiple myeloma remains generally incurable for now, these newer therapies have significantly improved median survival rates. We are transforming a once rapidly fatal disease into a much more manageable long-term condition.
Which leaves us with this final, provocative thought. If our greatest cellular defenders, the very plasma cells designed from birth to keep us alive, can mutate into our greatest threats, how close are we to finally outsmarting them completely? As our understanding of genetics and cellular pathways like IL-6 deepens every single day, the cure might actually be closer than we think. Thank you so much for joining me on this deep dive into multiple myeloma. Keep learning, stay curious, and I'll catch you on the next explainer.